Welcome to Open Studio on Brattleboro Community Television. I'm your host, Chris Lenois, and today we're visiting with Dr. Louis Josephson, who in January became President and Chief Executive Officer of the Brattleboro Retreat. Dr. Josephson, welcome to the show.
Thanks for having me.
I should also say welcome to the community. You just came here most recently from Los Angeles. You were the CEO of Vista Del Mar Child and Family Services. Now, some would say that sounds like a pretty good gig to leave to come to Vermont in the depths of winter.
Yes, but I always tell people I was in New Hampshire before we went to Los Angeles, and I didn't leave because of the weather. It's not a reason to stay or go, so I'm happy to be back, and I love New England.
Yeah, indeed. No stranger to the Northeast. Your doctorate at NYU, your master's at Columbia, a bachelor's at Tufts, facilities in New York and New Hampshire, as you just mentioned. Was it coming back to the Northeast that really compelled you, or was it something about this job opportunity?
Well, I think it really was the job opportunity. For people in the mental health and substance abuse field, the Brattleboro Retreat has a tremendous reputation over many years, back to the 1800s, and so it's a rare opportunity for someone like myself to come in and lead an organization that's got such a fine reputation.
Now, it's always heartening to hear that institutions here in our little hamlet have this kind of reputation, but still, there's always challenges with the population you serve, stories you might hear, things like that. Talk a little bit about, as you were doing your research, what you learned about the Brattleboro Retreat and then made you say, this is a really good fit for me.
Yeah, well, the Brattleboro Retreat, again, it's a rare organization. It is a freestanding psychiatric, what I would consider a health system, because we're not just inpatient hospital stays, we're also outpatient counseling. We do substance abuse treatment. We know there's a big substance abuse issue here in New England right now. So it's a big, complex organization. And what I learned was what you learn about most organizations. There are some things that have gone really great. We've had a lot of growth, and with that comes a lot of opportunity. At the same time, we also have to consolidate what we've grown into and make sure we're doing an outstanding job throughout. So every organization has its warts, and the retreat certainly had, but the thing that drew me, I'd say, more than even the reputation, and I was just this afternoon talking to one of our patients as I was walking through the hospital, and he said to me, it's the feeling here. It's the feeling that staff care so deeply about the people we serve, and that is something that you just can't value. It's just an amazing thing, and if there are other issues and things we need to improve on, that's one thing, but if you don't have that feeling of caring in your culture, that's almost impossible to inject into a place.
Now, you bring up the addiction issue here, and that is the need. There is a fortunate aspect to it, though, in that the state of Vermont is actually aware of that issue and dedicating a lot of resources to it. From an outsider's perspective, still a little bit, wondering what you think about how Vermont is approaching this in terms of priorities. Are they putting the right things first?
Well, I think they are. I mean, I'm heartened to see that the governor has made big speeches about this, has had pieces in the New York Times editorial pages. It is a real crisis for our communities. What we're trying to do is make sure we've got a robust clinical treatment model to respond to it. And I think we've taken some steps in that regard that are great in terms of access to care. I would argue we would like a little bit more oomph in that we can give people inpatient care when they need it to ease their detoxification symptoms and get them on the pathway to recovery. So I think there's more we could do that would be helpful for the population, but kudos to everyone here for recognizing and starting us down that pathway.
Yeah, well, it's hard, I would imagine, translating some of those things that you talk about from a clinical level to a policy level. Is that part of the issue here, communication gaps in terms of explaining some of the things that you need to people who need to find out ways to fund it?
Yeah, I think that's always true. When you have clinical expertise, our psychiatrists, psychologists, social workers who work in the programs, we need to be able to be clear about what the needs of our patients are. And so that's a critical piece. The big piece is always money. And we understand the economy in Vermont. We understand that there's not, pockets of money to just throw at problems. On the other hand, part of my job will be to say to people, you have to look at the hidden costs to this issue. Loss of productivity, families that are torn apart and kids end up in foster care, criminal justice costs. So we think we're saving money sometimes by not filling out the treatment possibilities, but in reality we may be paying much higher costs elsewhere in our systems.
Well, now, reputation certainly helps the retreat in that regard in terms of people looking to your organization for treatment. How about geography? Just thinking about that for a minute. Obviously, bordering New Hampshire, Massachusetts, even close to New York State, you can serve a broader population from here in Vermont.
Yeah, and we certainly do serve a diverse population in terms of geography, all the areas you just talked about, and even people coming from all over the country at times. But our mission and our focus is always on Vermonters. That's what our priority is. So literally every morning when we have our rounds meeting and see where we have open beds on our inpatient units and see what the demand people waiting or asking for service, we always prioritize Vermonters. And that's just who we are, and we're trying to serve our community first.
Oh, okay. Yeah, I wonder, especially with Vermont Health Connect, the own exchange here in Vermont under the Affordable Care Act, and I've had conversations with Steve Gordon at Brattleboro Memorial Hospital about some of those sorts of invisible barriers that stop at state lines, and that actually does create some problems in terms of the type of patient that they can care for and things like that. Is there similar challenges in the mental health?
There are. Our concerns are usually not quite along those lines. We're usually able to tweak things and work sort of patient by patient if we need to make an arrangement so they can get services. Our concerns really are around parity, and that's been the big issue, I think, in mental health. And I don't know if you've had those discussions on this program, but that's a big concern for us, is the parity issue.
Well, and certainly interested in hearing your thoughts about, again, getting back to the healthcare system as it's set up now. We seem to be moving more towards an area where we're thinking more holistically about the patient, right? Not just the physical ailments, but the mental ailments and the way they kind of work together. I mean, you're nodding your head because this is absolutely, you're kind of thinking this is about time.
Right, absolutely. So parity has been around for a long time, but it did get inserted into the Affordable Care Act, which was terrific. And all it says is, I don't know, parity doesn't always make sense to people as a slogan, but what it really means is if you were sick and you went to see your primary care doctor and you had pneumonia, and he said, I need to see you 5 times to start the treatment and follow up and make sure you're really in good shape before we clear you. There's nobody who would question your doctor and say you can't provide those 6 visits. But what we've had on the mental health side is that someone like myself or one of our psychiatrists sees a patient and says, I need 6 sessions or 10 sessions or whatever it is. The commercial insurers and other insurers are able to say, well, no, that we will only approve 4 visits. Mm-hmm. And it is not fair and it's not equal in terms of how we treat people with mental illness and substance abuse disorders.
Now, if you could put it on a continuum in terms of where we started and all the way to 10, saying, we're where we need to be in terms of thinking about these patients holistically, giving them the services they need when they need them, where would you put us?
I'd say we're still in the very beginning, 2 or 3.
Yeah, under 5.
I'm afraid so. It's not that people are not meaning to do the right thing, but literally it's often house by house fighting. It's like with this patient, we have to argue that they're not getting the right treatment and the right amount that they deserve under the Affordable Care Act. So it is still an ongoing process for us. Yeah.
When you reach out and have these conversations with other health professionals, health leaders, not mental health and physical health, talk a little bit about the bonds you're able to forge, talk a little bit about some of those understandings you're able to realize.
Yeah, absolutely. Go to any primary care practice. Go to your gastroenterologist for your colonoscopy. Ask those doctors about mental health issues in their patient panel. They will all tell you. It happened all the time when I was in New Hampshire. I went to get my colonoscopy. What did my doctor say? I'm ready to get my service, and all he wanted to talk about was so many of my patients with GI issues and irritable bowel. He said it's all mental health. Yeah. They don't need colonoscopies. They don't need my care. So the healthcare professionals feel inadequate serving these people. They're not well trained to do it, and yet they see it every day in their practice. So I'm really optimistic that between the concern from the health community, health doctors and nurses, and where we're going with funding models, will encourage encourage the embedding of mental health services within primary care, within medical settings, so we serve that whole person.
Yeah. Is it one of those funding models, the blueprint for health, these community health teams? Is that something that I know they're integrating a lot of different services to manage chronic conditions?
Yes, and that is a great example. So we know, for example, that if you have diabetes, there's a high incidence of depression with people who have diabetes. Similarly, if you've had a major cardiac intervention, very high level of depression correlated post cardiac care. And so, why wait till somebody is not functioning, not able to work? Let's get in there, assess people, treat them, just make it part of their care package. So we had actually worked when I was at Concord Hospital in New Hampshire to make sure that everybody who went through the cardiac catheterization lab was followed up with a depression screen. It takes, literally, it's a 9-question screening tool, and it can really save time, money, and patient suffering.
Yeah. Is it a situation where the retreat almost becomes an organization in and of itself of the community health team? And in other words, you're taking your clinicians and saying, all right, you would be best in serving this practice or this population, you would be as well?
Yes, and I think we've taken initial steps down that road, but it could be developed much more in the future.
Could you elaborate on how you would want that to be developed?
Yeah, I think we need counselors in all the major primary care practices. It's a great thing. We're very concerned at the retreat and have done a really good job, I think, with our anti-stigma campaign. Mm-hmm. So the beauty of having a counselor embedded in a primary care practice is you go to your PCP's office, they don't know if you're going to get your blood drawn or see the doctor or the nurse or the mental health counselor. So it immediately destigmatizes the whole act of getting service. You're not going to a mental health center, you're just going to the doctor's office. So we'd love to see more of that.
Oh, I love that idea, and I love that you're tying that to the Stand Up to Stigma campaign. I know that's been a big success story here in the community to try and raise more awareness about the community perception around mental illness. And we're a community, we pride ourselves on being one that provides a lot of services, and we also pride ourselves on being pretty tolerant.
Yes.
Ethnically, sexual preferences, people with disabilities, a lot of services there. And I used to do some work actually for a company that helped people with disabilities find jobs. And the big word there was inclusion.
Right.
And that's a word I keep hearing now around mental health as well.
Yeah, absolutely. The incidence of mental health is high. Most people, the majority of people in their lifetime are going to have some mental health issue with themselves or their families. And so it's it should be about inclusiveness. We have this thing, anything sort of from the head up is different than from, in the rest of your body. So we just want to get the word out there that if you have a mental health issue or a substance abuse issue, there's nothing wrong with you. It's probably a combination of your genetics, of your life circumstances, of so many things, and there's no reason not to get help.
Right. Well, but it's not just a PR issue. This is actual therapeutic value in terms of having a community understand the need to be more inclusive, I would imagine.
Absolutely, and these are our friends, our neighbors, people we see at church and the co-op. I mean, these are people who just need some support.
Yeah. Talk a little about what you've seen from the retreat doing outreach to the community and how you think that can be built upon.
Well, I'm still very new in my position, so I haven't seen a ton of that, but it starts with our materials. It starts with doing shows like this, which talk about it in the community. So there's a lot more we could do, but I think, again, that's a whole other program probably just to talk about our anti-stigma campaign.
Yeah. Well, interested to know, again, getting back to some of that experiences I had with people with disabilities and the tension between inclusiveness and also privacy. Right? And that's an even deeper issue when you're talking about people with mental health issues and needing to disclose those in a way so people have that understanding. Mm-hmm. This is going to be a whole other landscape that I don't know if the retreat is really, is it part of their role? Do you see that as part of their role to really foster this sort of better understanding in workplaces, in schools, and in public environments?
Yeah, absolutely. I think that's where the rubber hits the road, where people are, schools, home, workplaces. Absolutely, that's where we need to get the message out. And it's remarkable when you come into a community new like I have and meet people in all different parts of the community. It's almost invariably after every meeting, somebody takes me aside and says, "Louis, I want to tell you about my friend with a mental health problem, my brother with a mental health problem." So this is not something that's unfamiliar to people. It's just been something culturally that we've been ashamed of or haven't felt there's so much stigma around this. We need to change that, and I think people are very open and have already had these experiences.
Right. And then how about from the patient side in terms of understanding what they need to do in order to be sensitive to their needs, but also to be forthcoming with what they're experiencing?
Yeah, of course that's going to be a person-to-person decision, what they're comfortable with, but we want to make them aware that they have rights to certain access of treatment, and if they're not getting it, they need to speak up. If you had a kidney problem and you needed treatment, you would say, hey, wait a second, this is not working for me, and they have the right to do that.
Yeah. I've often, in conversations over the years living here and known many people who have worked at the retreat, always been amazed at the number of populations you serve,
right.
The number of different people who access services there, but also the age groups.
Yes.
And I know that you do a lot of work with adolescents.
Right.
I would like to just give you a chance to talk a little bit about what's happening right now in terms of working with that population
with
of
teenagers.
patients.
Yeah. So we serve both children and adolescents in our inpatient unit. We also have a school for kids with special needs, including emotional behavioral disorders. We have residential programs for teenagers who may be in a foster home and it's not working out, or their own home and their behavior is so intense they can't be safe in their own home. So we do quite a bit along that continuum. We also serve really as the state psychiatric hospital for children and adolescents. There's no other inpatient facility in the state of Vermont. So we see some kids with the most intense acuity and need. So we do quite a lot with the younger folks, and that's been kind of my interest in my career. I've sort of ended up a little bit more with child and adolescent work than I had with adult work over many years.
No, was that just was that personal preference, or did some things in your career just kind of guide you in that direction?
You never quite know. When I left my training, I thought I really wanted to work with adults, and then I was sort of
not challenging enough.
Not
Let's
challenging
work with a
enough.
teenager.
And kids are, I love working with adults too, but kids, there's a certain hope if you get in there early enough that we can really change the course of their illness and their functioning.
Well, I hadn't realized how exclusive the relationship was between the state of Vermont and the retreat in terms of you talking being the sole
There are literally
provider.
no other inpatient beds. So again, this is where we're always sort of ensuring that Vermonters get access to those beds first. But it is also a challenge because we could use more capacity in that area.
Yeah, I mean, is that something you're having conversations with the state about?
Yes, that, and also we would like to redo the inpatient facility and hoping we could get some capital improvement money or partner with the state around improving that space.
Yeah, would that be an expansion in addition to an improvement?
It could be, but right now I would just take the improvement, and even if we couldn't expand it, I think we have this beautiful historic campus, but some of the facilities really need some sprucing up. It's safe, it's fine, but it doesn't work for kids in 2016.
So it's not really capacity that's the issue, it's more of just kind of upgrading and updating.
I'd say that would be a great first step, but if we could talk about capacity as part of that discussion, maybe it would make sense to do them both at the same time.
Okay. Just in terms of your own philosophy of leadership, in terms of what you think now over the years, your different experiences, things like that, you come to a new organization like the Brattleboro Retreat. They had some great leadership before you in Rob Simpson, and not saying that you're going to come in and change things 100%, but certainly everybody who comes in as a leader has a mindset in terms of how they would like to see things happen. And just talk a little about yours.
Yeah, my philosophy is really centered around the patients and the people we serve. That is it 100%. And I tell the board of directors and I've told the staff, I don't know who you think I work for, but I work for the patients. And so I've got to come in every day and feel like I could look everyone in the eye and say, you got the best possible care and experience that you could have at a place like ours. And so until it gets to that level, you're always trying to get perfect, I'll never be satisfied. So it always boils down to that, making sure our patients get a great experience every day. And in substance abuse and mental health treatment, you never know if that inpatient stay is going to be the one that's going to get them on the road to recovery and better functioning and really, have their life take off. So I take that responsibility very, very seriously, and that's always my main focus.
I mean, again, getting back to the breadth of services, the breadth of population, the number of people you employ, that's a pretty tall task for you to take on such a individual level.
It is, but it's a great organizing principle, because if you come back to that patient experience every day, it talks to, are we training our staff up to do the best work? Is the physical plant designed to give them the best care and safety? Have we gotten the word out and made sure that people know that we are high quality service? So it's the one thing. It's about, we really exist only to serve patients and their families. That's the only thing we're there for.
Let's talk a little about the future now. Obviously, it's maybe a little bit difficult to do that being just a few months into your tenure here, but certainly when you look at an organization and what you knew about it and what you know about the healthcare landscape, you must have some ideas as to 5 years out, 10 years out, what direction you see the retreat going.
Well, it is a little bit early, so don't pin me down too much on this, but I do think there's a lot of opportunity for us. We are this wonderful resource here in the southern part of the state. I think we have to look, as you were pointing out, what's happening in that bigger healthcare arena and where do we fit in that. I'm all about being lean and mean and making sure that we don't overbuild our capacity but don't underbuild our capacity. So you need to take the time and step back and say, with state partners, with local partners, with Dartmouth, Hitchcock, whoever it might be, what is the best role for the retreat in our system of care in this area? And so that's the kind of conversation I know our board is going to be talking about, we'll be talking about with our leadership, to make sure, again, are we meeting the needs of the community and doing it in a very efficient way.
Now, you brought up Dartmouth Hitchcock, and I know we have the Accountable Care Organization relationship with them, with our hospitals here, but is that something that the retreat is part of as well?
We are part of, we're in the discussions. We're sort of, sometimes mental health and substance abuse is in like the second wave. They're not quite sure how to work us into things. But I've been saying to my counterparts, even in the first few weeks, you better be thinking about us and the people we serve, because that's such a key component of the bigger service picture. And if you're trying to even save money on healthcare, again, back to the person with diabetes and depression, if you're only treating the diabetes, you're not going to do as well with that patient as if you're taking care of the depression as well. So we're very actively involved with the Vermont Hospital Association, all of these initiatives, but we're not always on the front burner with the rest of the hospitals.
Yeah. How often are you able to look outside of the healthcare field for data? Like, for example, I was just having a conversation with a group earlier this year about population in Vermont. I was actually surprised to see it's not as much of a net drain as people are making it out to be. It is still, we're losing more people than we're gaining.
Right.
But by a very, very small fraction. These are really important things for you as you think about capacity, as you think about the populations you serve. There's a whole different set of things you have to do for somebody who's 65 versus somebody who's 18.
Right, so we will step back and look at all of the demographic information, and we do know we have an aging population in the state, and so what does that mean for their care? So absolutely, that'll be a part of our strategic planning.
Yeah. Are you going to find any time to have any fun here in southern Vermont too?
I hope
while
so.
You do all
I'm
this
a
work?
snowboarder, but you guys didn't deliver any snow this season, so I'm out of luck. But you might see me running around town. I'm a big runner, and I need to do that for stress relief, and it's also just a fun thing to do.
And your family, you said that they're still over on the West Coast now, but they'll be joining you here sometime soon?
Yeah, they'll be out here in the spring after my daughter finishes high school, and I'm looking forward to being reunited with them again. That's been the most challenging part of my experience, is not the retreat, which does a great job, but just being away from my family. We're not used to that.
Yes, indeed. Well, we're very happy to have you here in the community and really appreciate you taking the time today.
Great, thank you for having me.
Dr. Louis Josephson of the Brattleboro Retreat, thank you for your time today. This concludes this installment of Open Studio on Brattleboro Community Television. Be sure to visit BrattleboroTV.org for airtimes and to watch this episode on demand.